SGLT2 is a new type of medicines which have been used, SGLT2 inhibition, that means a treatment modality which is primarily for diabetes patients. So we will talk about proof of concept, SGLT2 inhibition for heart failure, care beyond diabetes. That means whether this medicine can be useful in the heart failure, and this is because this is primarily a medicine for diabetes. Then we'll talk about clinical evidence in patients with chronic heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction, and heart failure with preserved ejection fraction. Then we'll talk about initiation and stabilize acute heart failure and early outcomes. How should we stabilize this? Then we'll talk about optimization of place in heart failure therapy. These are 4 points which I'll discuss. So the first point which I want to discuss was EMPA, which is one of the SGLT2, induces modest glycosuria in patients without diabetes. The most important apprehension which any patient or any doctor will have, that the patient who are non-diabetic, if they start taking this EMPA SGLT2 inhibitor, they will have hypoglycemia. Any physician will see, if I am giving a non-diabetic patients, he might have hypoglycemia. So we have seen that glycosuria within 24 hours after single dose is not much. So we have very limited glycosuria, and therefore this apprehension should not be there. If you see the patient in people without diabetes, if you give EMPA, does not significantly affect fasting or PP plasma glucose levels. Fasting plasma glucose, if you see, is not much affected with single dosage. So the chances of glycosuria is not much. The second proof of concept is effect of SGLT2 inhibition in pathophysiology of heart failure. So first of all, we have proven that this will not cause hypoglycemia in non-diabetic patients. Now what we are talking about, that these patients will have some positive effect in the pathophysiology of heart failure. That is why they are useful. So they will reduce the preload. The important part of any heart failure treatment is in afterload reduction and preload reduction. And this is done by increasing free water clearance, decreasing the stressed blood volume. This is very important, because this is the thing which is the reduction in stressed blood volume is only achieved by EMPA. It also reduces the pulmonary vascular pressure and also decreases the intraglomerular pressure. On myocardium, it increases the metabolic efficiency, diastolic relaxation is increased, increase in oxygen demand valence, decrease in LV hypertrophy, and decrease in the LV remodeling. And afterload reduction is also achieved by this. So overall, by giving SGLT2 inhibitors, we have improved cardiac functions. This is the proof of the pathophysiology. EMPA reduces stress blood volume in patients with heart failure with reduced EF. This was published in recently and with a clinical heart failure, and this is part of EMPIRE heart failure study. So it reduces the stress blood volume, which will help in the positive effect, as I told you, it will have positive effect in preload reduction, and which will cause betterment in the heart failure patients. EMPA directly improves the diastolic function in human heart failure. This is also a study which has been proven that cardiomyocytes isolated from patients with heart failure preserved ejection fraction from healthy donors. EMPA improved diastolic stiffness and diastolic function in human cardiomyocytes. This is a very important point which I want to highlight, that this has got an improvement in diastolic stiffness and thereby improvement in the heart failure. EMPA improves the cardiac structure and function in patients with heart failure and reduced ejection fraction without diabetes mellitus, and this is very important. You can see EMPA tropism study which has shown that this also has improvement in cardiac structure and functions in patients with HFrF, which is heart failure with reduced ejection fraction without diabetes. Similarly, in patients without diabetes, improves the cardiac function in patients with HFrF without diabetes mellitus, improves cardiac function in patients with HFrF without diabetes mellitus. This is, I think, repeating the slides, but they are different indicators. You see LV ejection fraction, peak VO2, maximum LA volume, minimum LA volume. All these things are actually indicators for improvement in cardiac function in patients with heart failure with reduced ejection fraction without diabetes mellitus, especially LV mass index, LV ejection fraction, sphericity index, and other parameters. So I have already discussed about the proof of concept, how SGLT2 inhibitors for heart failure can help in patients without, beyond diabetes, heart failure. Now coming on to the clinical evidence in patients with chronic heart failure, chronic in all three modalities. Heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction, heart failure with preserved ejection fraction. So I want to give you some highlights about the clinical evidence. So Emperor-reduced study, phase 3 randomized double-blind placebo-controlled trial has shown efficacy in primary outcome as well as key secondary outcomes. So primary outcome is CV death and hospitalization for heart failure, and key secondary outcomes are total hospitalization for heart failure and slowing of kidney functions decline. And it has been shown to be, to change this, it has been shown that there is a hazard ratio of 0.75, that means 25% risk reduction, and in NNT with absolute number 19, that means if you have 20 patients treated, 19 will have benefit effect. So EMPA improves heart failure outcomes in patients with heart failure with reduced ejection fraction. This is a clinical study which has shown risk reduction of heart failure by as much as 25%, which is clinically significant. EMPA consistently benefits patient group with heart failure reduced ejection fraction. If you see in CV death or hospitalization for heart failure, irrespective of diabetes mellitus, age, RNA use, and aldosterone usage, irrespective of diabetes mellitus, RNA usage. That means it additionally causes support in patients of heart failure by decreasing the CV death or heart failure hospitalization risk reduction. EMPA does not worsen overall safety outcomes. So safety outcomes is very important, because in a patient with diabetes, you are worried about diabetic ketoacidosis, you are worried about the severe hypoglycemic events, you are worried about confirmed hypoglycemic events, and of course we are already worried about genital tract infection because it causes glycosuria. So patients with diabetes or without diabetes, there is no worsening of overall safety outcomes if you add SGLT2 inhibitors with or without diabetes. EMPA lowers risk of serious kidney disease and heart failure, reduced ejection fraction, a study which has shown, and risk reduction of as much as 50%, hazard ratio of 0.5. So this is very important, that it also reduces, or it reduces the acceleration of the eGFR reduction. That means the kidney damage is slowed down by usage of EMPA. In addition to this, Emperor preserved study, phase 3 clinical trial have shown in patients with heart failure injection more than 40%, that means mid-range, and they have shown that composite primary endpoint, time to first adjusted educated heart failure, and confirmed secondary points, they all are improved in these patients. EMPA shows consistently efficacy in heart failure in mid-range ejection fraction and heart failure in preserved ejection fraction, and this was a study which was published recently in AHA November 2021, American Heart Association sessions. LVF 41 to 49 and LVF more than 50%, and you have seen the risk reduction of 29% and 17% in placebo and heart failure, hazard ratio 0.7 and 0.8 in CV death and hospitalization for heart failure. EMPA consistently benefits patient group with heart failure, preserved ejection fraction, and heart failure with mid-range ejection fraction in terms of CV death and HHRF, irrespective of diabetes mellitus, age, and CKD or atrial fibrillation, irrespective of patients having atrial fibrillation. So coming on to the EMPA, lower the risk of CV death or heart failure hospitalization patient across the spectrum of heart failure, all spectrums, CV death, hospitalization for heart failure by baseline ejection fraction. That means not only in the preserved or mid-range, but also in the, not only in the reduced ejection fraction, but also in the preserved and mid-range ejection fraction. So I have discussed now the clinical evidence in patients with chronic heart failure. Now we'll talk about how to initiate and stabilize acute heart failure and early outcomes. How to initiate the SGLT2 or EMPA in stabilized patients. So if you see the IMPULSE study, which is recently published in European Heart Journal, failure in 2021, in hospital initiation of EMPA in stable patients post-acute heart failure, when the patient is stabilized, and these are patients, 530 patients have been taken EMPA 10 mg, they were followed it up with placebo, and primary endpoint was death, number of heart failure events, time to first heart failure, and they found inclusion criteria and exclusion criteria. The inclusion criteria was currently hospital for primary diagnosis, stabilization criteria should be there, randomization after 24 hours, elevated NT-proBNP, and treatment with a minimum dose of 40 mg of intravenous furosemide. Exclusion criteria was cardiac shock and of course prior acute coronary syndrome, MI, stroke or TIA, and eGFR less than 20, that means severe kidney disease was exclusion criteria. And this was a study which has actually, in these patients, they have compared EMPA with placebo in acute heart failure, which has stabilized. And they found that all of the following criteria must apply for the inclusion. Systolic blood pressure should be more than 100. There should not be any increase in IV diuretic dose for 6 hours. No IV vasodilators, including nitrates, within last 6 hours, and no IV inotropic drugs for 24 hours before stabilize. That means we have to be very sure that these patients are actually stabilized after acute heart failure, and they found that all-cause mortality was 4.2% versus 8.3% in placebo group, and heart failure event was 10.6% in EMPA and 14.7% in placebo group. That means EMPA was found to be very useful, 36% greater likelihood of clinical benefits in EMPULSE trial. That means found to be very useful in the patients who have got acute heart failure and who have stabilized. Earlier we were talking about chronic heart failure. Now we are talking about EMPULSE study has shown in acute heart failure. This is summary of the adverse events. Overall adverse events in EMPA and placebo was not different. That means it was reasonably safe medicine in acute heart failure. This is what the EMPULSE study has shown, that it is useful in heart failure, reduced ejection fraction, heart failure and preserved ejection fraction, in diabetes, in non-diabetes, in hospital treatment initiation. This is what EMPULSE study has confirmed. So coming on to the optimization of place in heart failure therapy, to summarize that what is the optimum place of EMPA in a heart failure treatment, you have to start with, all the patients of heart failure should be given beta blocker, should be given RNA, should be given aldosterone, and should also be given SGL2. This is what is the latest current guideline. So foundational therapy of heart failure with reduced ejection fraction includes SGL2 other than beta blocker, RNA or ACE and MRA. So this is important summary of this whole talk. Similarly, heart failure ESC statement recommends maintaining SGL2 inhibition across all types of 9 patient phenotypes, all types of blood pressure less than 90/60, blood pressure more than 90/60, blood pressure more than 140, no atrial fibrillation or atrial fibrillation, no CKD or CKD with hyper, and even the blood pressure less than 60, more than 70. So all these places, this should be given and can be given without any second thought. So if you have some additional medicines can be added. If you have a patient with increased heart rate, you can add ivabradine. If you have reduced heart rate, you should reduce the beta blocker dosage. And similarly, these are the heart failure position statement in HFA ESC, European Society of Cardiology. This is an important slide just to tell you that step 1 in any patient with heart failure, stable heart failure with reduced ejection fraction, we always give beta blocker. Step 2 is angiotensin receptor blocker. Step 3 is mineralocorticoid receptor antagonist. But here SGL2 has been positioned in number 1 step along with beta blocker in all cases of stable heart failure with reduced ejection fraction. This is the most important part. Why beta blocker is always? Because there have been many trials have shown very effective for the risk of sudden death, which is a common problem, a common fatality cause in all the patients of heart failure. The chances of sudden death is increased, and that's why beta blocker gets step 1. And at the same place you have got SGLT2 inhibitor. So this is what this is what I was saying, that in hospital day 1 to 4, day post discharge, days 7 to 14, days 14, 28, 21 and beyond, RNA, beta blocker, MRA, SGL2, all these things have to be taken, and we have to be very, very judicious in using it. And this, the final statement will be that all the patients should be given other than the beta blockers, other than the RNA, which is the combination sacubitril along with ARB, along with mineralocorticoid antagonist, SGL2 inhibitors along with beta blocker, should be initiated in all the patients irrespective of diabetes. That's the most important. Normally this SGLT2 inhibitor medicine is given in diabetic patients. But if you have a heart failure patient, then you have to add this medicine from the beginning in chronic heart failure. In acute heart failure also, impulse study has shown that it should be used after stabilization. And most important part is, even if the ejection fraction less than 30 or mid-range more than 40 to 50, and even with preserved systolic ejection fraction, it has got a beneficial effect in all types of heart failure, in terms of reduction of cardiovascular events, in terms of reduction of risk of hospitalization for heart failure, and therefore increasing the longevity. Thank you very much. I hope I was clear in telling the importance of EMPA or SGLT2 inhibitor in all the paradigm of heart failure, irrespective of diabetes mellitus status. Thank you very much.